Hello, everybody.
Good
Can you
evening.
guys hear me?
Yes,
Yes?
Yes, I
yes,
Okay.
also can hear you.
yes.
How are you?
Okay, good. So let's begin now. I would like to introduce Professor Dr. Sutha from Thailand. Dr. Professor Sutha is a professor emeritus at the Institute of Molecular Biosciences and director of the Thalassemia Research Center, Mahidol University, Nakhon Pathom, Thailand. He is a very famous clinical researcher and also a professor in hematology. He is recognized for his study and research in thalassemia, especially in Thailand, and he has a lot of collaboration with universities in China as well as other countries. So, and actually, every year, Mindray invited Professor Dr. Suthat for a guest speaker and also coming to China, to Shenzhen, and to offer a face-to-face seminar. And we have been good friends for a couple of years already, right, Dr. Suthat?
Thank you.
I visited, visited Thailand more than 2 years ago, and we had a good time there too. Very happy there. So, okay, tonight we are going to have a seminar on HemaTalk again, and Dr. Sutha will be the chair of the whole seminar. So now I would like to hand the host to Dr. Sutha. Okay, Dr. Sutha, are you ready?
Yep. Thank you. Yes, thank you very much, Henry. So for today webinar, I think that it is quite timing that we will talk about the change in hematological parameters in COVID patients. And as everybody witnessed, that starting from the end of the year 2019 to uh, the whole year of 2020 and still the early of 2021, the whole world has a pandemic of this COVID-19. Many contagious cases and many death cases in different countries. And even though the uh, criteria for diagnosis for COVID-19 is by molecular diagnosis, RT-PCR, the antigen antibody screening is still useful. And definitely, routine hematological parameters, hematological change is still very important because when patients come into the hospital the first time, they did not say that they come with COVID, but they come with different kind of symptoms. And the CBC is the first thing that patient will receive. So it's very good opportunity that today Myray has brought up this issue to review what kind of hematological change in COVID patients. Our guest honorary speakers, next slide please, is Professor Joseph. Uh, can we have next slide please? We have Professor Joseph Onofrio. Professor Joseph now is a Professor Emeritus at the Catholic University of the Sacred Heart in Rome, Italy. Professor Joseph used to serve as a vice president of the International Society for Laboratory Hematology and also the former scientific secretary of the International Committee on Standardization Hematology Cytometry. Very importantly, at the moment, he is a co-editor-in-chief of the former journal of the ISLH, that is the International Journal Laboratory Hematology. Professor Joseph has also sit on many other committees, scientific journals, and on flow cytometry, hematology, and clinical pathology. So, Professor Joseph, today you will be our guest lecturer to review hematological change in the COVID-19. Just want to introduce other speakers. Next slide, please. Professor Henry Huang. Professor Henry is the adjunct professor of oncology in the Department of Surgical Oncology at Roswell Park Comprehensive Cancer Center in Buffalo, New York. And he has conducted many research both in US and China. At the moment, he serves as a senior director of medical and scientific division of Myre in vitro diagnosis. Now we will start our presentation of Professor Giuseppe. Yes, please. Professor Giuseppe?
Yes, thank you very much, Professor Suta. I'm very happy to be here. First of all, I try to share my screen, and I think now you can see what is one of the last slides. Let's go. Okay. Okay, so good morning, good afternoon, good evening, wherever you are. Thank you very much for joining us here in this very interesting meeting. And when I was asked to give this lecture, I've been thinking about what could be the best way to approach this huge topic of COVID-19. And I decided to use my position of co-editor of this journal, the International Journal of Laboratory Hematology, IJLH, which is published, has been published for I would say 40 years. Previously in its version, which was called Clinical and Laboratory Hematology, a more open journal to clinical aspects and experimentation. And since starting from 2017, I think, it became as it is now, the International Journal of Laboratory Hematology. I decided to exploit this position because of the many contributes we had received and in this topic. And so I will try to describe what is our experience in comparison with other important papers which have been published in the rest of scientific literature. I just want to remember that this journal is today also the official journal of the International Society for Laboratory Hematology. We will have in the next few months the virtual meeting of the ISLH this year. Next year, in 2022, we hope to go back to be in presence. I also want to remember that my co-editor is Ian Mackey from London, and we are working very well together. He's an expert in coagulation and hemostasis. So this is what we have until now. I just want to start to show you that the International Journal was already involved in some reports concerning the SARS in 2005. So someone had used from China, had used the journal to communicate that hematological issues could be present in that disease. And then with the MERS, also there were colleagues who had reported their information about hematological abnormalities together with in this other coronavirus disorder. Now we have, until now, about 51 papers, but this number is changing almost every day, and 31 articles and letters on hemocytometry and morphology, so the description of what is blood from the point of view of the cell composition. Hemostasis and coagulation, we have 14 articles. Some of them are very nice, and other topics, 6 articles. So this is how the story started for us. If you look at the dates in the upper part of the screen, this is where the first case is in Italy. You know, Italy was the first country in Europe to be involved in the pandemic, and the first area was this very rich and very crowded part of the north of Italy, Bergamo, a city in which there are a lot of people working in companies and the industry, and they still are deeply involved in the problem now. You see that when the first patient was described it was Saturday, February 22. And at that point, there was a big sudden change in how the hospital had to deal with this increasing number of patients. They had to open new units dedicated to these patients. They had to increase greatly the number of beds in ICU. And we, from the journal, we decided that we wanted to have some contribution from that hospital. We knew some good hematologists there. Sabina Boro was, I asked her to give her opinion on what was happening from a point of view of the laboratory hematology. So this is the first paper we had. It's an editorial which appeared on March 25. And it's interesting to see that it was received on March 22 and it was published online after 3 days. Do not expect that every manuscript will have the same fate on the times of publication, which usually are a bit longer. But in that time, there was a big effort, the publication office, the editorial office, where everybody was involved to try to improve. So this was the start. After that, we had this is just examples of papers published in 2020. And you see that we have, the first ones are on clinical characteristics of these patients from China. And already very early, a lymphocyte count was recognized as a prognostic marker and so on. Interestingly, we can say that a large number of these papers came initially from China. And well, we noticed that the level of article coming from that country has certainly been improving very much in this last year. Interesting also, you see that this with the e-letter here are letters sent to the journal, not full article. We had many of these letters on different aspects. We have been very open to accept this type of contribution. Besides articles and letters, we also have published a number of reviews. These are 4 reviews which have been, which are on the journal, and which review all the aspects from the point of view of the hematology laboratory. And you see this one was published quite early, I think in April. Volume 42 was for the supplement of the ISLH Congress in May, summer. And there was a paper on neutrophilia. There was a paper here, which was a scoping review of the literature. And I show you some data. And this is a very recent paper from Iran, if I'm not wrong, high quality paper, which explorates, which describes the different features, a good, very good overview of the hematological abnormalities. This is just the example of the scoping review we have published, and which is now in volume 43. And just to show you that how many papers were found after a search through databases, almost 5,000 papers were found, and after screening, excluding those not related to laboratory hematology, we have found more than 700 papers, and then we did further screening and excluded also those in which full text was not available, which is a rarity for COVID. You know that literature is almost all free to read. And eventually we included 402 studies, and we could appreciate some of the features I will show you. And we can confirm that almost half of the study originated in China, and many of these studies were articles with retrospective clinical studies was certainly the main type of article. And there was also a clear bias in favor of retrospective clinical studies and letters to the editor, and also interesting narrative review articles. You can see here the different hematology indices, how were found in this scoping review. 20% deal with white blood cell, 2% lymphocyte, 14% neutrophil, an important population, platelets, and some minority, the monocytes, and the interesting neutrophil lymphocyte ratio and eosinophils. So this is just an overview of what was happening, not in the journal, but in the general literature. So I will go quickly through the what are the main findings in this. Let me check the time because I don't want to be late. Okay. So red blood cell and platelets. Red blood cells, well, this is not a major abnormality in these patients. Anemia is not specific. It's not an outstanding feature of these disorders. Blood bank was not severely involved even in the first period in our experience. Of course, anemia can be present in severe cases, and it is usually related to some underlying disorder or preceding, or some disorder which develops during the disease. Of course, coagulation abnormalities are a problem. An interesting observation concerning red blood cells comes from this study by my colleague Dr. Wang and his co-authors, originally published as a short paper in the Mindray Press Center, now published in two different versions in a revised journal. I will show you now a few how this marker can be useful. So on platelets, I found that there is a large heterogeneity in how platelets are found. Of course, platelets are, it depends on the course of the disease, on the complication. But in some studies published in our journal and in other journal, platelet is associated with severity. A drop in platelet count is more common in non-survivors, and also a peak is not a good sign. Someone has proposed the platelet to lymphocyte ratio as a prognostic factor. And we, from our side originally, we just in the first patients, we saw that platelet in this patient had some sort of morphological abnormality, developed maturation abnormality. And someone has also published that megakaryocytes in bone marrow have abnormalities. So we found, especially in some patients, some large platelets with increased chromomer at the center, granulations, and large cytoplasm. You see the sort you see in some hematological disease, but this is certainly not a myelodysplasia. It's just a reactive bone marrow. This is from the paper by Wang and co-workers, in which you can see here how using the RDW, there is an increase of RDWs SD in critical patients. And this is an interesting finding. And I'm also interested in their finding concerning reticulocytes. In critical patients, they found a higher reticulocyte, even very high, you see more than 4%. You can see them on the BC6000 screen here, increased reticulocyte in severe and especially in critical patients, and also increase in IRF, immature reticulocyte fraction, and in the percentage of hypochromic red cells, with an increase of low hemoglobin concentration. So this is new, interesting information which should be confirmed by further studies. White blood cell count, well, we don't have a clear picture, of course. White cell count depends on the different subpopulation, which change differently. Frequently, we have leukopenia. Higher white blood cell have been described in non-survivors and may predict poor clinical diagnosis. But it's more interesting to look at the population at the different fraction of leukocyte. Of course, lymphopenia is almost a universal finding, and it has been recognized very soon after the beginning of the diffusion of the disease. And it has been documented in 40 to 90% according to different studies. And it is a prognostic and predictive marker, especially in critically ill patients. And it can herald the development of ARDS, in admission to ICU, and even death. And it has been observed that the nadir lymphocytes is 1 week after symptoms, and that patients, improving patients, have a normalization, a restoration, which predict a good outcome. Of course, the automated analyzers are basic. We are talking about this pattern of hematological changes because we have automated instruments which give us a lot of information, accurate and with a very low imprecision, so we can compare all the data. The analyzer flags many of these samples, 10% in a published study, usually for abnormal lymphocyte or even blast. There is an increase in hyperfluorescent cell and an increase in what some call the reactive lymphocyte cells. With flow cytometry, there is a decrease of lymphocytes in all population, which is to a greater extent for CD8 positive cells, but there is no usually inversion of CD8-CD4 lymphocyte ratio. So all lymphocyte population are involved. And this is explained, all this finding of lymphopenia by different mechanisms like depletion of T cells, exhaustion, and or direct invasion by the virus and lysis, and the activity of cytokines, which of course are the main what causes the cytokine storm, which indicates a bad course. Lymphocyte morphology, this is what we see in some patients in which the activation of lymphocyte has been described by many authors. This is one of our study published in another journal very early in April, and we saw in the first patient a high degree of activation with different feature, lymphoplasmacytoid plasma cell with plasmablastic feature, reactive lymphocytes with similar to those found in mononucleosis, infectious mononucleosis, immunoblast, LGL are usually present in blood with many evident granulations, and even cells with cytoplasmic inclusions have been described, smudge cells. And this is for one paper, this is from one paper published by Sadiq and co-workers in the IJLH, and you see how many cells they have photographed here to show the different types. The main finding in their study is this sort of blood of blue, large cytoplasm, plasmacytoid cells with a clear area near the nucleus. They also have found that the typical finding is smudge neutrophils. And neutrophils, of course, are an outstanding feature, in our opinion, in a variable proportion of cases. And increased neutrophils are combined with increased risk of the respiratory complication and also with decreased lymphocytes and risk of death. We had observed at the beginning that just one or two cases had reduced myeloperoxidase activity, and we were interested in that using, of course, the automated cytochemistry analyzer. And we were interested in that because we did some studies about the reduction of peroxidase in activated neutrophils, but I can tell you that this was not confirmed. So this is just an isolated finding. But of course, the activation of neutrophils depends on the cytokine stored, and maybe also on superinfection by bacteria. And there's this study in our journal has shown it's a meta-analysis which shows that even if there is a higher heterogeneity, elevated neutrophil counts correlate to the mortality. But we were impressed by the morphological changes at the beginning. I'm not going to read everything, but just to show you how, for instance, these cells have a high hypergranular cytoplasm with the even high hypogranular areas, and a nucleus which has problem for segmentation. So this can similar to a band cells, but again here, and this is more like a pseudopelger cell with vacuoles, similar to those we can find in some myelodysplasia patients. But this is, again, this is something which is transitory, reversible, so it's not a problem of myelopoiesis, it's a problem of reaction, hyperactive reaction to these cells. And these are the smudge cells that Sadiq and co-workers have described also in our journals. These are some other aspects we have described, and you see this is a real pseudopelvic neutrophil vacuolated and with toxic granulation, again pseudopelvic unsegmented nuclei, and it is almost a blast cells or immature promyelocytes, and again hypogranularity or pseudopelvic aspects. And this is a finding we can have for any type of cells, lymphocytes or neutrophils or even monocytes, apoptosis. We see usually in severe patients apoptotic cells. Well, in this hematological, from the hematological point of view, we have seen that there are many reports of lymphocytopenia associated with neutrophilia or abnormal neutrophils. So I think I'm not an extreme supporter of the ratio between cell population in general. But in this case, my feeling is that it's really an interesting observation, given the different behavior of the two populations. So we had at least 4 or 5 papers in the international journal. There are more in the rest of the literature, and which report that lymphocyte ratio is a predictor for disease severity, and is associated with some alteration of lymphocytes sometimes. And this is another journal, but you see 3 to 5 for severe disease, and this is Chan International Journal of Laboratory Hematology found this difference between neutrophil between patients which were not in ICU with NLR of 2.03 and ICU patients with an NLR of 11.2. So it's a big difference. And the correlation found by you, also published in our journal, with a correlation, for instance, with procalcitonin, with C-reactive protein, and also with the dimer. So it's interesting. This is an interesting parameter. I think it's the best utilization is in this condition. And this is again from the study of one who used Mindray ABC 6000. He has published that given the behavior of the neutrophil lymphocyte ratio and the RDW, he has put the two together as produce his own index, which maybe will have a use in the future. So it's an interesting fact. You see, as he was able to separate all the severe cases using this index. We have some findings about monocytes also published. Of course, monocytes are activated. It's difficult to say when a monocyte is activated. You see this type of cells. Sometimes, and this is our experience, it is difficult to recognize morphologically a monocyte, an activated monocyte from a hyperactivated lymphocyte. For instance, this type of cells, it's difficult to say if it is a monocyte or it is a lymphocyte. I have my opinion, but I leave it to you, the decision, because we have vacuoles, we have a rather clear chromatin nucleus, and so on. From instruments have shown that there is an increased monocyte volume distribution in patients compared to controls. We have at least three or two papers describing these findings. And this leads us to the cell population data. Well, you know that now the big instruments give us a lot of numbers concerning cell volume, cell content, light scatter properties, fluorescence, etc. So neutrophils, lymphocytes, and monocytes are very well characterized. Until now, we have a number of papers on this. They are increasing in the last few months, and results certainly are not totally clear. They are contradictory. Certainly, the different brand instruments cannot be compared easily one to the other. And however, this is an area in which certainly we will hear something in the near future. And finally, I want to tell you something about eosinophils, which are the only population left. I've seen that there are a few, one or two contributions about this, so I don't want to spoil their presentation, but it's important, however, to anticipate that eosinophils are show changes in patients with COVID-19, and but with some heterogeneity. Here, however, we have the most common finding is eosinopenia, a decrease in neutrophils, which has been described also using the BC 6000, and we have also seen in some cases a dysmorphism, not as strong as the one seen in neutrophils, but however substantial in some cases. In these studies, more than half of the patients with COVID in Wuhan had eosinopenia on the day of hospital admission. So it was not an effect of steroids. It's probably related to the cytokine storm or other effects. This is a recent paper just published online in the International Journal of Laboratory Hematology from India, in which on more than 400 patients, 79% had eosinopenia. However, an important information is that this eosinopenia, for some reason, has not a very strong prognostic significance. There was no difference between survivors and non-survivors. So you see that the median count on admission was not very, very different. And we know that eosinophils are active in antiviral activity, but they can be also dangerous in some way. But however, it's important, something which was shown early in the pandemic, that patients with eosinophil disorders are not at increased risk for severe disease. Asthma and similar problems are not associated with poor outcomes. And this is at the beginning was quite a surprising finding, but now it's very clear and confirmed. And also vaccines do not have, even if some complications were seen originally in animals, but no complication concerning eosinophil have been reported with the current vaccine. And in conclusion, I think that while eosinopenia has been identified as a factor that may facilitate disease, or however is frequent, but it's not pathognomonic at all. They have been included in several algorithms, and in general, the author think that this is a secondary phenomenon, not directly contributing to the disease course. So they do not have a protective or exacerbating role. At least this has not been proven until now. We don't. The reason for this eosinopenia is obviously multifactorial. We have so many factors that can act on eosinophils. One, of course, is the addition of corticosteroids, but cytokines and factors, chemotactic factors are also certainly important. So I will conclude by saying that from the point of view of the International Journal of Laboratory Hematology, we have seen a storm on us by authors of manuscripts. And really, I think that the quality, the average quality of these manuscripts was certainly higher than the quality of the general quality of the papers I've seen in the last year. So it seems clear that this pandemic has had maybe, I don't know if it's the only, but one of the very, very few positive effect on scientific communication. And certainly this is also due to the decision to leave free to read all the papers on this topic. Another important point is that the role of hematology analyzers in the description of hematological abnormalities has never been so important, because of course hospitals are full of patients, laboratories are full of samples, and it would be impossible to have so many data without a powerful machine and quick instruments which can give us millions, billions of data in one day. Certainly, we are waiting for further information from maybe cell population data or other factors, which are other information. So thank you very much for your attention.
Very much, Prof, for excellent presentation. And now the floor is open for a few questions and comments. Now we have a question from participants. The first one is from Dr. Putri Chandaja. I think that she must come from India. The question is that in severe patients, we found any abnormality, especially in the morphology of neutrophil. And for her experience, she found some toxic granules and some also in the lymphocyte, not only in the neutrophil, okay? And large lymphocyte and lymphoplasmacytoid, but never plasma cell, okay? Would you like to make any comment or reply to that one?
Yes, I confirm everything, and it's interesting that this colleague has not found plasma cells. It's true that you don't find, even in my experience, true mature plasma cells. You especially find lymphoplasmacytoid lymphocyte, even very extreme morphology. About neutrophils, I fully confirmed. It was really, we were impressed at the beginning in the first slides we saw from the first severe patients coming to the hospital about the problem in segmentation of nuclei and different granulation, toxic granules, of course. I also thank you for telling that sometimes granular cells are lymphocytes. We also have seen extreme form of hypertrophy of NK cells or LGL lymphocytes. Totally agree with this.
Second question from Dr. Putri as well, concerning the giant platelet, because you know that if you look through the slides, sometimes not easy to find or identify giant platelet. So she last question that in the case of giant platelet, can we take a look at the mean platelet volume, and can we use this mean MPV is correlate with COVID-19 infection? Because if it works, that will help a lot when we look at those MPV. Yeah.
Yes, this is a very good point. to measure MPV is not easy because you need a very good standardization of samples. All pre-analytical factors must be under control because MPV is quite changes in time. And I think that, well, Dr. Putri, if you have these data, why not to prepare a manuscript for the journal or at least a letter? That would be great.
Thank you. Any other questions or comment? Oh, we have a question from Dr. Ratna from Indonesia. What is each kind of hematology analyzer instrument need to establish their own out-of value for detection of severity of COVID infection? It's pretty about the lymphocyte ratio.
I think that all the instruments of the top level instruments have a good can give good information. I think that well, we have seen manuscripts using the Mindray, using the Beckman Coulter, using the Sysmex, of course, XN, and also we did experience with the Advia, which also gives information. And so I think that any instrument can give some information. The problem is that not always these information are comparable. If you go to the sophisticated parameters, each instrument has his way of measuring these parameters. So it will be, I think, one of the most important things to do in the future is to assess how comparable are the cell population data between the instruments.
I have other questions, comment from Dr. Ep.4. The comment is about schistocyte in patient with COVID who is not doing well. Have you seen this or not?
Well, as far as I know, I've not seen any description of schistocytes. It would be really interesting, and I can expect some abnormalities, the presence of some red cell fragmentation in patients who have a disseminated intravascular coagulation, of course. As far as I know, I've not seen description of this as a primary abnormality. However, thank you for the question, which is really interesting.
I think that we have to finish this question, okay? And you still have a chance at the end of the presentation that we have 20-minute free talk that you may bring up these topics again, okay? So next, we will go to part 2 of the presentation of today's seminar. Can I have next slide, please? Altogether, we have received cases for presentation and case sharing with other participants, 12 cases. And the committee has selected out 5 cases for presentation today. We will start with the first case. After the brief, try to keep your time of presentation not more than 15 minutes, okay? And then we will have a comment or questions organized from our speakers like Professor Giuseppe or Henry or myself on each cases. So we'll go to the first case, please. First case is hematological abnormalities among COVID-19 patients in Addis Ababa, Ethiopia, by Dr. Moges. Please, Dr. Moges. Yes, please. Dr. Moges, the floor is yours.
Thank you for the opportunities. My title is Hematological Abnormality among COVID-19 patients at Millennium COVID-19 Treatment Center in Addis Ababa. And these are
Speak a bit louder. Speak to the microphone. Speak a bit louder.
Okay. So these are the background, the materials, the result, and the discussion. So by now we all are familiar with the COVID-19 disease, the route of transmission, and so on. So I will directly proceed to the hematological findings common among COVID-19 patients. So there are the common hematological findings among COVID-19 patients like lymphopenia, thrombocytopenia, and leukopenia that we that's indicated in the large size studies in China. So our methodology, a prospective cross-sectional study, was conducted from May to July 2020 at Millennium COVID-19 Referral Treatment Center. The center served as the first COVID-19 referral treatment center with more than 1,000 beds. Convenient sampling technique was used to select 334 patients, and we exclude those patients with underlying chronic disease. So socio-demographic data and the disease severity status of the admitted patient were collected by reviewing medical records. We categorized the patient into 3 groups: moderate, severe, and critical patient. We collect the venous blood in ELITE test tube to determine the complete blood count, and the quality of the test were maintained by running 3 commercially prepared quality control materials, and the integrity of the sample were checked regularly. So when it comes to the result of 334 admitted COVID-19 patients, the majority of the patients were females, 62.3%, and relatively most of the patients were in the age group of greater than 50 years. And regarding on severity, 69.8 patients had moderate disease, while 12.3 patients were in the critical condition. And regarding the overall magnitude of hematological abnormalities, magnitude of any cytopenia, meaning anemia, thrombocytopenia, or leukopenia, is 41%, and that of pancytopenia were 1.8%. And of those cytopenias, anemia were predominant, which is 24.9%, and thrombocytopenia were 21.6%. And the most common hematological abnormality were lymphopenia, which account to 72.2%. So this is a table that shows hematological abnormality among COVID-19 patients at Millennium COVID-19 Center. And as you see here, among cytopenias, the most common one is anemias, and leukocytosis account around 29.6%, whereas neutrophilia account 50%. And again, pancytopenia account for 1.8% of the participants. And regarding the severity of anemia, the majority of those anemia cases were mild, which is 12.57%, and there are only 1.2% severe anemias. So the magnitude of anemia was relatively higher among males. And on the other hand, the odds of anemia was 2.3 times higher in patients with severe than moderate conditions, with a significant association. And patients with a critical disease condition were 2 times more likely to develop anemias than moderate patients, but with a marginal association. So this is a table that indicates the association of anemia with disease severity and the socio-demographic status of the patient. And as you see in the table, the anemia is positively correlated with the disease severity, 2.35% and 2.35 and 2 times more likely to develop severe and critical disease than that of the moderate patient. So the magnitude of lymphopenia is also similar among critical, severe, and moderate patients. So there is no significant association between lymphopenias and disease severity. So as you see, the magnitude of lymphopenia was similar among moderate, severe, and critical patients, but with no significant association between lymphopenia and disease severity. So on the other hand, binary logistication of combined lymphopenia, neutrophilia, meaning that patients both having lymphopenia and neutrophilia were assessed, and those patients with a severe and critical disease were 4.1 and 3.3 times more likely to develop combined lymphopenia and neutrophilia than moderate patients with a significant association. So again, this table indicates the association of combined lymphopenia and neutrophilia with a disease severity, as well as socio-demographic status of the patient. And patients having both lymphopenia and neutrophilia were significantly associated with the disease severity. As you see in the table, both shows significant association, 0.02 and 0.27. So in addition, the study revealed that patients with a severe and critical disease had 2.7 and 3.3 times increased risk of having neutrophilia. So neutrophilia is also associated with increased risk of disease severity and progression to severity. So again, this table shows the patient with a severe conditions had 2.7 more likely to develop neutrophilia than moderate patient. And in the same way, patients with a critical conditions are 3.3 times more likely to develop neutrophilia than the moderate patient. So both indicating significant association of neutrophilia with the disease severity. When it comes to discussion, upon admission, the majority of the patients had lymphopenia, 72%, whereas 50% shows neutrophilia, and 29.6% presented with leukocytosis, while 24.9% and 21.6% of the patient had anemia and thrombocytopenia, but only 5.4% of the patients showed leukopenia. So several studies identify leukopenia as a reliable marker of disease progression to severity, with a magnitude higher in dead and ICU patients than non-severe or survivor patients, but this is not the case in our studies. So this might be due to the comparable magnitude of lymphopenia among moderate, severe, and critical patients. So the study by Young et al. Also support our finding, showing that there is a significant change in lymphopenia between non-severe and severe patients. So provided that lymphopenia is not specific for COVID-19 and is also common finding in elderly, the predictive capacity of lymphopenia will be improved if it is combined with other parameters such as neutrophilia and high neutrophil to lymphocyte ratio. So in this regard, our study demonstrated that severe and critical COVID patient had 4.1 and 3.3 increased risk of developing combined neutrophilia lymphopenia than moderate patient with a significant association. So I'm audible? So in most studies, neutrophilia was common finding in severe patients, and a study in Singapore among 130 post-ALS patients showed that neutrophilia was significantly associated with admission to ICU. Similarly, our study also showed that neutrophilia were more predominant or more prominent in severe and critical patients than moderate patients with a significant association. So regarding anemia, unlike most studies, we showed no profound finding on anemia or no significant association between anemia and the disease severity among COVID patients. Our study showed that there is a significant association between the risk of developing anemia and the disease severity. So the critical and severe patient had increased risk of developing anemia than moderate patient, but with slight marginal association. And similarly, the study by Bellman also showed a significant association between anemia and increased risk of in-hospital mortalities. So finally, with regard to leukocytosis, both severe and critical patients also showed a significant association with leukocytosis. Similarly, a multi-center retrospective study in China also revealed that leukocytosis upon admission in COVID patients were significantly associated.
Dr. Mukesh, have you finished your presentation? Yeah. May I invite Professor Joseph to make a comment on Dr. Mukesh's presentation, please?
Yes, just a short comment. It's another good presentation, and I think that the data obtained from this country, from this continent, are for the majority.
Sorry for the. Sorry.
Yes.
Sorry for.
Dr. Morris, are you there?
There's an internet connection. Sorry for.
Dr. Mukesh?
I'm here.
Okay,
Yeah.
good.
Okay.
I was just commenting your presentation and your study, which is very well done, and it's interesting to see how the blood in COVID is in a new country, in a new continent, on which we don't have yet many information, and it's for the big part your data confirm what has been seen in other. In Asia or in Europe or in the United States, and I've seen that you have an important degree of neutrophilia in your cases, which is confirmed to is an indicator of worse conditions. And also anemia was a bit more frequent that in the majority of the studies. However, thank you very much. I don't have a specific question, but your study is really interesting.
Thank you very much, Dr. Marquez and Professor Joseph. I think that we have to go back to next case's presentation. That will be from Dr. Ida, the second case, COVID-19 with eosinophilia. Yeah, Dr. Ida Tabet from Kuwait, please.
Good afternoon, all. Thank you so much for acceptance of our presentation in Parwania Hospital, Kuwait. We will start now with our one of the most recent case in Parwania Hospital about COVID-19 with eosinophilia and if there is any association or not. We have 33-year-old Kuwaiti gentleman who is heavy smoker and known to have mitral valve replacement type, not on anticoagulation, presented with shortness of breath on 17 February 2021. Nasopharyngeal swab for COVID-19 taken. By chest examination, there is decreased air entry on right lobe and right lower zone, no organomegaly, lymphadenopathy, or hepatosplenomegaly by examination. Radiological investigation shows right posterior basal subsegmental pulmonary artery embolism with mild right pleural effusion. Our laboratory result on admission, CBC shows normal white disease count, lymphocytosis 4, but the patient has already lymphocytosis before admission, 2 years before this admission, has persistent lymphocytosis, and eosinophilia, which is recently appeared with CBC on admission. Our blood film morphology show leukocytosis, absolute lymphocytosis, absolute lymphocytosis, absolute eosinophilia, reactive lymphocyte, red cells and platelet are unremarkable. For clinical evaluation, viral screening rule out secondary causes of eosinophilia and follow-up of lymphocytosis. Blood film morphology, as you see here, there is eosinophilia and lymphocytosis. Most of them are reactive lymphocyte. But morphology-wise, there is something strike our eyes in this case. The patient has about 50% of eosinophil has trilobes, not only bilobed like normal eosinophil. No, most of them, or 50% of them, near 3 lobes, and most of them also show vacuolations with many reactive lymphocyte, neutrophil, unremarkable morphologically. By coagulation profile, this is normal coagulation profile, except the D-dimer is high, 624. Upon admission, the patient was hemodynamically stable and improved symptomatically with antibiotics and started on rivaroxaban. COVID-19 nasopharyngeal swab came positive on 18 February 2021, and he is improved clinically, as we said, so he insisted to go home for self-quarantine. The patient on 3rd of March, the patient presented again with worsening shortness of breathing, follow-up CT chest revealed worsening of right pleural effusion, therapeutic pleural tapping of 1 liter was done, and sample sent to the lab for further workup, as we see later. Laboratory result at that time show of the pleural fluid, as we see, show white disease count for 1,796, which is very high per microliter. Morphologically, they are polymorphonuclear leukocyte, about 50-50, up to 50-50 polymorphonuclear leukocyte and 50% mononuclear leukocyte. The predominant cells are lymphocytes and eosinophil, and by chemistry show exudate, as we see the pleural LDH is very high, albumin, total protein, and glucose. This means this is exudate. Pleural tab culture shows no organism after 5 days incubation, and acid fast bacilli for TB also was negative. Laboratory result for cytology examinations of the pleural fluid non-conclusive because they doubt this may be contamination from the blood, contaminated from the blood, and the recommendation to repeat the case. So our timeline, brief history: the patient admitted on 17 February 2021 for swab of COVID and CT angio positive for subsegmental pulmonary embolism and mild pleural effusion. On 18, a result to come for swab as positive, and he insisted to go home against medical advice on rivaroxaban and antibiotic. On 3rd of March, he came later with bad presentations. He admitted due to worsening of shortness of breath, and CT chest showed worsening of right pleural effusion, therapeutic pleural tapping of what later done. And on 18 of March, the patient discharged home on anticoagulant and antibiotics after improvement. Laboratory result, as we see for CRP on admission, the patient has high CRP 42. Then during the admission, it is improving, the CRP result, and 2 days before discharge, decrease level up to normal. Yeah. It is 12 and normal 8. This is good for the prognostic marker for this patient. What about the CBC finding? CBC showed lymphocytosis, which was previously present prior to his first admission. However, eosinophilia was of new onset. As we see here, laboratory result, accumulative CBC result. On 19 December 2020, the patient came from the hospital with, as we see, lymphocytosis, and this was persistently before because the patient is smoker. And the eosinophil level, it was at that time 0. This in December 2020. And on 13, on admission of February 2021, the patient started to increase the eosinophil 0.6. Then on 17, increased to 1, and in 17, again, also 1. This is 2 reading, 17, 2. This 2 reading in different times. Eosinophil in both of them is increasing level from 0.6 or from 0 level at December, increased to 0.6, 1, and 1. This means increasing the eosinophil count. Workup for lymphocytosis. The patient has persistent lymphocytosis, which is explained clinically as the patient is a heavy smoker. However, virology screen, immunology workup, and peripheral blood for immunophenotyping were sent to exclude other secondary causes of lymphocytosis, and they came back as negative. As for eosinophilia, it was clinically unexplained, and the following workup was sent to exclude possible secondary causes of eosinophilia. So the persistent lymphocytosis is explained to us as the patient is a heavy smoker. And also, we do all the workup for causes of lymphocytosis, and all of them came negative. But for eosinophilia, we are worried why it increased suddenly with this patient. If this is just secondary causes as inflammatory disorder, or the patient need more workup. So we send stool analysis, which is come negative for no ovocyst, no ova, cyst, or parasite seen, and stool culture with sensitivity by PCR negative for all microorganisms, as we see. For other malignancy causes of eosinophilia, we also do workup. These are able mutation for chronic myeloid leukemia, BDGFRA, B, and FIB1L1, all of them sent for myeloid lymphoid neoplasm associated with eosinophilia, and all of them come negative, and the JAK2 mutation. We also wanted to send c-KIT mutation, but was not available for mastocytosis. And chronic and acute eosinophilic leukemia M4, not indicated as there is no blast in the peripheral blood, so we didn't send the inversion 16 as laboratory workup for malignant causes of eosinophilia. Diagnosis description: this is a case of COVID-19 positive patient with a new onset of eosinophilia and pre-existing lymphocytosis, most probably due to smoking. Therapy and outcome. The patient improved clinically, and upon discharge, his CBC showed increase in eosinophil count compared to admission. And discharge, the patient has eosinophil count 1.4. Also for CBC parameters of this patient, we usually notice that the white BCs count total doesn't change at all throughout the admission of the patient, and usually the change between the differential count of the CBC. The lymphocyte usually increase by the time during the admission. The monocyte also most of time kept constant, and the eosinophil is increasing all the time. Other parameters, platelet count and hemoglobin doesn't change. Mainly it change between lymphocyte and eosinophil, but the white cells count total kept as it is. Now, is there is an association between eosinophilia and COVID-19? Yes, I can say for this patient, yes, but we need to do further study. Several studies were published regarding establishing a link of a prognostic value between eosinophil count and the clinical outcome of COVID-19 patients. Some of these studies are illustrated in the coming slides. This study done on Doha, Qatar, soon 2020, about clinical outcome of eosinophilia in patients with COVID-19 as a controlled study. And in conclusion, our study reports a relatively high prevalence of eosinophilia in symptomatic COVID-19 positive patients. Patients with eosinophilia had a lower level of CRP, and we will see this later in our case, milder clinic course, and better disease outcomes compared to those without eosinophilia. Our findings indicate a protective role of eosinophils in mitigating the severity of inflammatory disease through an inhibitory mechanism. As evidenced by lower CRP, this protective role of eosinophils needs to be validated by further prospective studies, and we also say the same. Eosinopenia and COVID-19 also. The patient when do CBC on December 2020, he has eosinopenia 0 level, and then it started to increase. So we check also if there is any relation between eosinopenia and COVID-19. In conclusion, this study also done soon 2020. In conclusion, absence of eosinophil count in a CBC can aid in early diagnosis of COVID-19. It may be a useful tool in deciding whether to promptly isolate a patient and initiate a specific therapy while waiting for confirmatory test results. Persistent eosinopenia after admission correlate with high disease severity and low rates of recovery, and this not happened with our patient because the eosinophil count increased. In conclusion, our patient developed a new onset of eosinophilia concomitantly with COVID-19 infection, which was complicated by pulmonary artery embolism and significant pleural effusion and high inflammatory marker CRP, which gradually decreased during the course of his illness. Eosinophil count, however, increased in an inversely proportional, and we should confirm this one, in an inversely proportional manner to CRP level. On admission, eosinophil count was 1, and upon discharge increased to 1.4. The patient clinical condition gradually improved and didn't necessitate transfer to ICU and was discharged home only after 15 days after his admission in a very good general condition. This graph shows relation between CRP and eosinophil count during the admission. Our patient on admission, CRP was 42, and then decreasing on admission until 12 at the time of his discharge, or 2 days before discharge. And this eosinophil count graph, patient admitted on 17 February, as we said, with mild increase of eosinophil out 1, and reach for the highest level on 11 March, and then discharged. Here it is 1.8, and discharged with 1.2 eosinophil on 18 of March. So this is good correlation between eosinophil count increasing and decreasing CRP as inflammatory marker. So can we say that eosinophilia was a reliable marker for the patient's overall favorable outcome despite having pulmonary complications from COVID-19 infection? And thank you so much for Dr. Dana Shakti for her help in the preparation of this presentation. Thank you so much.
Thank you very much, Dr. Ida. Can we have Professor Henry to make comment, please, Henry?
Sure. This is a very interesting case, and your talk was wonderful. So thank you very much. Actually, we had a similar result, which is published in another journal in January as well. We saw from 52 cases of COVID-19 patients. So their eosinophil was increased. So, but the thing is, we do find other publications mentioning about the eosinopenia. So instead of eosinophilia, so this should be cautious. So I wonder if there is a connection or correlation between the patient's age and severity. So we should pay attention to this kind of situation, pathogenesis of the patient during the disease course. So I would like to get some comments from Dr. Kishap upon this this idea. So then also I don't know if you had checked the HIV and also the mycobacteria in the sputum of a patient or even BAL fluid. So maybe we may have another clue on the patient. He may have another disease like tuberculosis or even HIV, because the patient is very young, so 30 something and with heavy smoking. Dr. Aida?
Thank you.
Yeah, doctor. TB acid fast bacilli was negative in this patient. Done already.
Saliva? Did you check the
Yes.
sputum?
Negative.
Yes.
Yes.
Yes. We checked sputum,
okay.
yes, for acid fast bacilli, and it was negative.
Okay.
I think that we have to move further. Thank you very much, Dr. Ida. Thank you, Henry. Case number 3. Can we move to case number 3? The comparison of clinical and diagnostic features of pediatric hematology oncology patients with and without COVID-19 infection. Yeah. Dr. Niram, are you ready?
So the topic of my today's presentation is comparison of clinical and diagnostic features of pediatric hematology oncology patients with and without COVID-19 infection. So here is a brief introduction of my study. As you know that reported literature supports that COVID-19 infection in children is usually asymptomatic or runs a milder course. The reports showed COVID-19 infection in 2% Chinese and 1.7% American children. And out of these, only few children had complications. However, few children as compared to general population are more susceptible to develop COVID-19 infection, like children with malignancies, immunosuppression, and hematological disorders. It is speculated that immunosuppression and chemotherapy may contribute to increased disease severity among these children. Furthermore, hematological malignancies cause multiple variations, not only the primary disease, but its treatment also. They cause changes in blood counts and particularly baseline hematological indices like hemoglobin, leukocyte, and neutrophil counts are often different from age-specific reference ranges. This may make hematological markers unreliable predictors of COVID-19 infection in children with malignancy. So the objective of the study was, it was actually a retrospective chart review to compare clinical features and laboratory parameters of pediatric oncology children with and without COVID-19 infection in order to identify factors predictive of COVID-19 infection and to determine features associated with severe disease, particularly in pediatric oncology patients. So it was an observation non-therapeutic study conducted in the hematology section
Hello,
of
doctor.
laboratory.
Sorry,
Yeah.
can I go to full screen? Now please go to the full screen. Thank you.
Okay. Right?
Okay, here.
So the study was conducted in The study was conducted in hematology section of laboratory, the Indus Hospital in Health Network, Karachi, Pakistan. And the target population was pediatric oncology patients tested for COVID-19 by RT-PCR from March 2020 to June 2020. We included both genders, and the age range was from 1 month to 18 years. And the patients included for the study were those patients tested for COVID-19 and CBC, both done after the onset of symptoms. So the statistical analysis was done through SPSS version 20 and history, particularly for chemotherapy, steroid, and analyzed surgical workup, microcardiographic findings, blood cultures, and the outcome of the patient. Mean, median, standard deviation, and confidence interval were calculated for quantitative variables such as factors. And these are the statistical tests, chi-square and Fisher exact and ANOVA tests were applied to identify the statistical difference, and a p-value less than 0.05 was considered as statistically significant. So coming to the results, if we compare both cohorts, these are pediatric oncology patients with COVID-19 infection without COVID-19. Mean age of patient was 9.1 years, and there was no significant difference in gender. Like male-to-female ratio was equal in both cohorts. Patients were given in COVID positive group, that is 48%, and solid organ tumors were slightly higher group. And CRP and TLC showed no significant difference. In terms of blood cell indices, absolute lymphocyte count was higher in COVID positive group, resulting in low NLR ratio in these children. I will show later in the graph. Okay, so the time for the viral clearance was longer in children with malignancies. PCR was repeated weekly. First, PCR was repeated after 14 days and then weekly. And we found that virus cleared after 14 days in 19% children, while 7% and 3% children required 21 and 28 days respectively to become virus-free. When comparing respiratory findings at admission, COVID-positive children were more likely to have ARDS and low SpO2 and FiO2 ratio. Notably, impaired cardiac function, especially left ventricular dysfunction and reduced ejection fraction was noted, more in COVID-positive group. When we compare mortality rate in both groups, patients with COVID infection were more likely to have fatal outcome as compared to children without COVID. That was 6.8 versus 2.7%. Here is the numbers are round off. So here's the graph of the CBC indices, and you can see in the figure A, there is a mean neutrophil to lymphocyte ratio, and in COVID positive group it was quite low, that is 1.7, while in COVID negative group it was found 2.9. Similarly, if we talk about SF ratio, it was 473 in COVID positive group, while 486 in COVID negative group. And the mean absolute lymphocyte count, it was higher in COVID positive group, that is 4.7, and observed lower in COVID negative group, that is 2.8. These are the mean of all the results. So here are the details of the results. You can see hematological parameters. If we talk about hemoglobin, total leukocyte count, and absolute neutrophil count, there was no significant difference in both cohorts. While absolute lymphocyte count shows a significant difference, that is, it is higher in COVID positive group and lower in COVID-19 negative group. And similarly, if we talk about neutrophil to lymphocyte ratio, it is lower in COVID positive group. If we see it and compare it with the published literature, it is quite low. The cutoff value we kept for the comparison was 3.1. And in our study it was found low. Eosinophils showed no significant difference. Hematocrit, platelet count, and other biochemical markers showed no significant difference. However, if we talk about the final outcome, the death rate was 6.8% in COVID positive group, while it was 2.7% in COVID negative group. This is the classical picture of CBC with a COVID positive patient. However, it was non-malignant case. These are the smear findings. Here you can see neutropenia, thrombocytosis, and leukoerythroblastic blood picture. And similarly, the case was from non-malignant patient. So if we talk about the severity of disease, 12% of the patients showed severe disease. While exploring risk factors of COVID-19 severity in patients with cancer, we found that older age, that is 8.4 plus minus 5.4 years, male gender, lymphocytosis, and low neutrophil to lymphocyte ratio were associated with disease severity. Additionally, there was greater evidence of ARDS and multiple organ damage in patients with severe disease. 2 children in the severe disease group had evidence of bacterial infection on basis of positive blood culture. So as we all know, CBC is a very important basic investigation that is done in almost all clinical settings and has been observed extensively in COVID-19 infections. In this study, COVID positive patients showed low NLR, while hemoglobin, leukocyte, and platelets count were almost similar in both cohorts. So comparison of both groups in our study showed similar clinical features, which indicate that signs and symptoms in malignancy and in children receiving chemotherapy may mimic COVID infection. In light of this, it can be stated that clinical features may not help physicians in identifying and predicting severity of COVID infection in children with cancer. So total 5 out of 73 COVID positive patients died, resulting in 6.8% mortality in this cohort, while it was 2.7% in COVID negative group. This mortality is slightly higher as compared to published international literature that show 4% mortality in patients with hematologic malignancy and COVID-19 infection. To our understanding, this mortality is multifactorial and possible explanation may be general health and compromised immunity due to poor nutritional status of our patients. Late referrals may also be a contributing factor. However, further multicenter studies are required to be conducted to ascertain these factors. So if we conclude it, these results have shown an important finding, that is lymphopenia and rising NLR may be a prognostic marker for disease severity in adults, but not helpful in children with cancers. Pediatric patients with malignancy and COVID-19 infections have different features as compared to children without malignancy. Among clinical features, cardiac dysfunction and ARDS differentiated between children with and without malignancy, and hematological parameters associated with COVID-19 infection and severe disease, including lymphocytosis and low NLR. These are the references I used in my study, and I would like to acknowledge my co-authors and my lab director, Dr. Sabarman. Thank you so much.
Thank you very much for your presentation, Dr. Niran. May I ask, invite Professor Joseph to make a question or comment to Dr. Niran first? Please, Joseph.
Yes, of course. Congratulations, first of all. The study was really well structured, and you have given us important information which show how the children population is different from adults, even more when they have this type of disease. They have almost go in an opposite direction because of their probably very reactive lymphocytes. And I think I would like, you had many patients with blood disorders. Have you seen in your patients any effect of this infection on the evolution of their disorders? There was any worsening of or no changes in their primary disorders, maybe some lymphoblastic leukemia?
No, not at all.
Okay.
No worsening of primary disease and no impact of chemotherapy and steroids on the acquisition and the severity of COVID infection. We did not observe any finding like that.
That's interesting. Thank you very much. I think it was a great presentation and a very good study.
Any other questions or comment to Dr. Nilam?
Yes, I would like to have a question for Dr. Nilam.
Please.
Yeah.
Henry.
Hi, Dr. Nilam. Dr. Nilam,
Yeah, I can hear you. Please
hello.
go ahead. Yeah,
Oh,
I can
okay.
hear you.
Okay. Yeah, just like Dr. Kishap mentioned about your
Sorry.
study result.
I cannot hear you. Can you please repeat your question?
I think that we have to move. Sorry, Henry. Yeah, because we have some connection and we have limitation of time. Now, next presentation uh, about pneumonia COVID-19 with acute myeloid leukemia from Dr. Miftah Hassana from Erlangga University, Indonesia. Please, Miftah.
Okay, thank you. Can you hear my voice? Okay, can you hear my voice now?
Yes, yes.
Okay, thank
Go
you.
to the big screen. Yeah, yeah, good. Full screen presentation. Yes, you can start now. Yeah, good.
Okay, thank you so much for the opportunity. My name is Miftah Hassana. I am from Erlangga University. Here, I want to present my case in hematological abnormalities in COVID-19. The title is pneumonia COVID-19 with IML M7. Male, 24 years old with blood cough, fever, abdominal pain, nausea, vomiting, and bleeding in gum. GI tract, and also there's a blood in faces, also with weight loss and loss of appetite, and confirmed for COVID-19 on day 3. Then the patient moved to the isolation room, and then the patient slowly started to feel shortness of breath and bleeding. The total day in isolation room was 42 days. Then the patient moved to high care unit. There is no history of past illness. So this is the serial of complete background result on the patient. There was anemia and the thrombocytopenia here, and the leukocyte was within the normal range. There was increment, but never in size condition. So these are the trends of hemoglobin, white blood cell, and platelet parameters. From the hemoglobin here, we see that there's a persistent anemia. The first hemoglobin was 6.5. There was increment of hemoglobin level on these patients. Maybe this was because the patient received the blood transfusions during the treatment. But overall, the hemoglobin was never in normal range. It's just like a 6 until 11 gram per deciliter. From the trends of the white blood cell, the first was 4,650 and it was on normal range, but there is the trend to become steadily decreasing and then increasing here. The increase should be due to the secondary infections as the patient starts with the shortness of breath, and on the chest X-ray there is an effusions which is worsening to the bilateral effusions. And then from the trends of the platelet, there was thrombocytopenia conditions. The trends went up and down as the days of the treatment. This might be because patient also receiving the thrombocyte concentrate, but never reached the normal range. This was not supported for the COVID-19 conditions only, because as we know in the COVID-19, usually there was thrombocytosis. So we have to suspect for another conditions from the first start because patients never went through the normal range for the platelets. This is the trends of the neutrophil and lymphocyte ratio. The trends showed match for the COVID-19 conditions on the first day, as we see that this is a 6.09, and the trends go lower and go lower, higher here, but on the day 16 or the day 27 is go lower. It's not match enough for the COVID-19 infection only, especially on this case. because the clinical condition on these patients was worsened. If the COVID-19 patient had a worse condition, the NLR should always high. As we know, if the neutrophil lymphocyte ratio is high, it means that the neutrophil count is increasing and the lymphocyte count is decreasing. But on these patients, this didn't happen. So we might conclude that something has affected to the production of the neutrophil and or lymphocyte in these patients. On this patient, NLR trend showed the good value of NLR, but it didn't go along with the clinical conditions. We suspect that there must be another disease or hematological abnormalities in patients. So this is the hematasis physiology parameters. This results. There was elevations on the fibrinogen and D-dimer level, indicating for the COVID-19 infections, but for the PPT and APTT within the normal range. And also, the clinical chemistry showed there is some abnormalities. This is matched with the condition with the patients who getting worse, but these parameters wasn't in line with the result of the hematological examination. And also patients going through immunological examinations has been done, but the increment of ferritin and procalcitonin is matched for the COVID-19. And some of tumor markers has been done in these patients as well to find another disease on the day 11. Here are the scattergram, which is very interesting in this case because this was the example of the scattergram on these patients. I took the CBC from the day 40, 41, and 45. All these three showing the same scattergram from the first day patient was treated. So there is an anemia here from the hemoglobin 8.8 and the thrombocytopenia for like 43,000 per microliter by the red blood cell within the normal range, but it close to the lower range of the normal range, lower limit of the. So we need to take a look at these abnormalities because if we think about the malignant hematology, we have to see the channel of the panels in the scattergram. We see from the WDF channel. In the WDF channel, we show the clear border between the lymphocyte and the monocyte. In the scattergram, we can see there's overlap between lymphocyte and monocyte. It indicates that there is cell which has the similar morphology with lymphocyte and monocyte. We suspect for a mononuclear cell. Then we look forward for the WNR channel. In normals, we find that in the left population here, it should be smaller than the right populations. And this WNR channel, in this WNR channel, we find that the left population is bigger. So it confirmed that there were indeed mononuclear cells. So we have to suspect for the findings of blast. Also, in this hematological analyzer, there is flagging here, blast and or abnormal lymphocyte and IG present. For the serial complete blood count show the same flagging and the same scattergram. So we move. So in these patients, we also done the blood smear evaluations, but this doesn't give much details on the abnormalities of because the WBC count was very low. We only find the atypical lymphocyte and immature granulocytes. There is also anemia and thrombocytopenia. And the BMA was performed after patient leaving the isolation room, which is not in when patient in the isolation room. That what we found was the blast form more than 20%, and the 50% was megakaryoblast with cytoplastic flaps, as we can see here. So the findings leads to the diagnosis for IML7. So the diagnosis of this patient is pneumonia COVID-19 with IML, which suggesting to IML suspected IML7. So this is the therapy for patients during the treatment. Patients get the PCR PRC transfusions, PC transfusions, but there is no therapy for IML that has been initiated for patients, and the outcome for patients died few days after leaving the high care unit. So we can confirm that case was COVID-19 with IMLM7 because from the WHO criteria is fulfilled, the bus is more than 20%, which of more than 50% is megakaryocyte lineage. The cytopenia and the morphology is similar with the criteria from WHO. We also we're also looking for the findings for AMLM7. We find from the American Society of Hematology, which is discuss about AMLM7 case too. There's a BAPS in the blood, which is similar findings with this case.
Dr. Mifta, can you go to your conclusion, please?
Oh, yeah, thank you.
Yes.
From the memorable notes is on this case, to get the long treatment for which wasting time, energy, and cost. And what we miss in this case is when we CBC saw persistent anemia and thrombocytopenia, we have to go forward for the scatter and suspecting for hematological malignancy as soon as possible. So in conclusion, and scattergram from hematological analyzer play important roles to suspect hematological malignancy. This is the reference. Then I would like to acknowledgement for our hematological consultant and supervisor, Dr. Ariful Hayat, and my colleague in hematological division in Sutomo Hospital, Surabaya. Thank you.
Thank you very much, Dr. Mifta. I just want to make a quick comment that you are right that the COVID-19 may occur in a patient with various kind of underlying or associated disease condition. So why the whole effort is putting on a COVID-19 diagnosis, treatment, etc., you can easily misdiagnose some other disease, underlying disease like diabetes, heart disease, including acute leukemia, like in your cases. Okay, what that I am not quite sure that it is a good observation or not is that all these hematological change like leukopenia, lymphocytopenia, thrombocytopenia, blah, 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 it is mainly from the COVID-19 or it comes from the leukemia. I think this is very difficult to justify in the case that have two disease conditions together. But the most important thing that we still want to hear from you more later is that what is the clinical cause of this COVID-19 in patients with leukemia, and vice versa, what is the clinical cause of acute leukemia patients in that happen to have COVID-19? I think this will be a big question and need further follow-up. Thank you very much for your presentation. I think that we have to go to the last presentation about from Dr. Emmanuel Ratan from India, from Chennai, about the D-dimer dynamics as a prognostic biomarkers of COVID-19 in intensive care as a tertiary care center. Okay, Dr. Emmanuel, please.
Yes, sir. I hope I'm audible, and I'm now going to share my screen as well. Yes. So good evening to everyone, to all the distinguished panelists and everyone gathered for this HemaTalk. So the topic that for today is that we had done a presentation on is the tertiary care center. So COVID-19 is a highly infectious and contagious disease, as everyone knows, and was declared as a global health emergency on 30th January 2020 by the World Health Organization. It initiates weakness, some symptoms like loss of smell. Hello?
Yes, yes. Continue.
Yes. Yeah. Thank you. In early stages, and some cases can even present with diarrhea and other such adverse symptoms. In some cases of severe COVID pneumonia, they can present with microthrombi formation as well. And so in these cases, the D-dimer count, D-dimer value, and the platelet count are useful laboratory prognostic markers to predict severity and outcome. So the aim of a study was to analyze whether platelet count and dynamic changes in D-dimer serial values could predict the severity and outcome in SARS-CoV-2 COVID-19 infection. because due to the severity of this illness, it would be valuable to explore the factors associated with adverse outcome and intensive care in patients with severe COVID pneumonia. And also, it will help us to analyze the mortality associated with it in order to take timely action and reasonable intervention to enhance cure rate and prognosis quality. So we wanted to analyze the importance of peak D-dimer value and the dynamic D-dimer values. And we also wanted to evaluate the significance of platelet count in severity and outcome. So the materials and methodology that was done, it was a retrospective single-centered observational study. It was done between May 2020 and January 2021. The study included patients who were admitted directly into the intensive. So all patients were confirmed by RT-PCR for COVID-19 infection. And then serial D-dimer and platelet values were collected from laboratory information system for each patient and were directly admitted to the intensive care or shifted to the ICU from the COVID ward due to worsening of symptoms. Statistical analysis was done using Mann-Whitney U test, and a p-value of less than 0.05 was considered significant. The inclusion criteria include all patients who were under the intensive care. We excluded patients who needed only home quarantine or hospital-based ward care. Right. So this is just the flow chart to give you an outlook of what was done in this study. So now coming to the results, we had a total number of patients were 239. The age of the patients ranged from 15 to 93 years, and the length of the hospital stay ranged from 1 day to 1 month. So, among the patients who were admitted from the ward from the COVID ward to the ICU due to worsening of symptoms, 70% were male and 30% were female. And the direct intensive care admission out of 110 patients, 73% were male and 27% were female. Coming to the outcome of all these patients who were admitted to intensive care, 90 of them recovered, indicating a 69% of recovered and 31% who died. In the direct intensive care admission, 60% recovered while 40% had an adverse outcome. So now coming to the individual platelet count analysis, as we took into account the patients who had an adverse outcome and the patients who had recovered. And as it can be clearly seen, a low platelet count as in patients with adverse outcome, as the duration increased during the stay in intensive care, showed significant p-value, indicating that low platelet count as disease progresses indicates poor outcome for the patient. Here we can see this this chart, which shows that the initial platelet values, if the patient is admitted with already existing thrombocytopenia, the patient had a poor outcome. Coming to the D-dimer analysis, the D-dimer analysis was significant throughout the initial D-dimer values and as the duration of the illness progressed in the intensive care, the p-value was significant. As can be indicated by this graph, you can see this. The curve for the initial D-dimer and the peak D-dimer are both above the baseline, indicating and the course of prognosis for the patient who were admitted in the intensive care. So coming to the final findings, initial D-dimer was elevated in both adverse outcome and patients who had recovered, and it showed a strong p-value positivity. Peak D-dimer was, although we didn't have a significant correlation, the values were high. It was also significant in patients who had recovered. Coming to the discussion, elevated initial D-dimer in patients with adverse outcome, as well as patients who needed ICU care, indicates an early underlying ongoing process of thrombosis and fibrinolysis. Patients with elevated initial D-dimer required direct ICU admission as a reliable marker of severity in COVID-19. Peak D-dimer elevation was significant in patients who needed ICU care. A decrease in platelet count was significant. Coming to my conclusion, initial D-dimer has a major role in deciding therapy and ICU care and is a significant indicator of mortality. Peak D-dimer is also a proven marker of mortality as indicated in many studies. We also have found high values in patients with adverse outcome, but not statistically significant in this study. Platelet count is significant with increasing duration of illness in patients with adverse outcome. I would also like to thank my guide and mentor, Dr. Ferdi Suman, for giving for help for all the guidance during the study, and my co-researchers as well at Sri Ramachandra Medical College. Thank you.
Thank you very much, Dr. Emmanuel. Henry, can you make some comment on Dr. Emmanuel's work, please? Henry.
Yes, it was a great talk, a great presentation. Thank you very much.
Thank you, sir.
Yes, actually, by reading a lot of publications, I found out that the D-dimer is very controversial with COVID-19 right now. You agree with me? So some people said it's increased. Some people said it's unchanged. Some people said even reduced. So I guess we should pay more attention to the correlation of D-dimer with the hospital stay and also with platelet number and other parameters of hematology. So we may pay closely attention to other correlations in the future. So maybe we can get more sound conclusions. So thank you very much.
Sure, sir. Thank you, sir. Thank you so much. It's been an honor.
Thank you very much, Dr. Emmanuel. Thanks, Henry. So we come to, before we move further to the third part of today's webinar, can we go back to the HemaTalk flow point? Well, next we will move to the third part of our webinar today, okay? Yeah, the free talk, okay? We have about 20 minutes. Before we start with some questions or comments that we have received from participants, I'd like to share with you the other 7 submissions. Can we have next slide, please? Yeah, we have submission about the from Dr. Karan in Pune, India, hematological abnormalities in COVID-19. Describe of the case of COVID-19 in a 31-year-old male presented at the hospital with fever. Okay, next cases. Dr. Karan, are you on online? Are you connected? If you are connected, if you want to make comment, you can make 1 or 2 comments about your presentation. The next one is from Dr. Jaya Lakshmi. No, can you go back? Can you go back? Yeah, talking about the dynamic neutrophil lymphocyte ratio and dynamic platelet ratio as predicted for severity in patients infected with SARS-CoV-2 COVID-19. Okay, very much the same as the previous presentation. Next slide, please. The next one is talking about thrombocytopenia in pregnant women with COVID-19 infection from Dr. Luhat Suryanugraha from Papua Barat, Indonesia. Okay, again, this is a description of a thrombocytopenia finding in a 19-year-old female pregnant woman. Okay, next slide, please. Next one is from Dr. I'm not quite sure that make a proper pronunciation, Veggies Khan from Turkey. Elevated eosinophil count is related with lower anti-factor 10A activity in COVID-19 patients. Okay, shall we move further? Next one is hematological abnormalities in COVID-19 again from Dr. Julian Nada from Sutomo Teaching Hospital, Indonesia. Again, this is a description of hematologic parameters change in the 45-year-old male that suffer from a cough, fever, and final diagnosis is COVID-19. Next slide, please. Next one is from Dr. Putri. I think Dr. Putri is the one who raised question, platelet and coagulation disorders in COVID-19. Dr. Putri, are you still connected? do you want to make comment on your case of 80-year-old woman present with shortness of breath? Okay. If no comment, we move further to next one. A case of hematologic abnormalities in COVID-19 at Eka Kotabe General Hospital. This from Dr. Yeshiva Mekwanit. This is the cases from Addis Ababa, Ethiopia. Well, this is a description of cases of 53-year-old male that get COVID infection. So we move to next one. Yeah, sorry. This is the 7 cases that had out of the 12, including the 5 presentation, that altogether we have 12 cases.
Sorry, Dr. Sudha.
Yes.
I think Dr. Yulia is. Dr. Yulia?
Oh, yes.
Yes.
Prof. Sutat, I want to ask.
Quick comment on your work. Do you want to do it, please?
Oh, yes. So in this case, 45-year-old male suffering from cough and fever since 7 days before admission with comorbid of obesity, class type 1 obesity, and also type 2 diabetes mellitus. In this patient, I found from the blood smear evaluation is only a typical lymphocyte, but from the white precursor cell channel, I found there were increasing of fluorescence intensity at SFL scatter plot, Prof.
What is the outcome with this patient? Because I've seen that he has all kinds of bad prognostic factor like coronary heart disease, type 2 diabetes, and then get septic shock. Did he survive or he expired?
I'm sorry, Prof.
What is the outcome in this patient?
The patient passed away, Prof.
Yeah,
the patient
yeah.
was passed away.
They have many complications. Yeah. Thank you very much.
Yes, right.
Any other
Yes.
questions, comment? So, if none, we will go to the announcement. Next, please. The free talk. Before the free talk.
Sorry. We think Dr.
Yeshua
Putri is also online.
Okay, please. Dr. Yeshua, you want to make comment on your paper? Or Dr. Putri, who will make comment?
Hello.
Who are you? Please.
This is Dr. Karan, sir. I have presented a case of APML in COVID-19 patient.
Dr. Putri, right?
Dr. Karan Maurya from Pune, India.
Oh.
The one before. Yes, sir, this case.
Yes, please. You would like to make comment on your
Yes,
work?
sir. This was a case of APML, but actually the cytoplasm was quite blue and the picture was not very characteristic. And we had, and even the WBC count was not that high. So we were, and the COVID positive report was weighing very heavily on our diagnosis and our differential. So I would just like to say, like, we should always keep our minds open and that we should consider all possibilities in COVID-19, and especially now when the prevalence is so high that all sorts of diseases can coexist with COVID-19. So thank you so much for giving me the opportunity.
This is from Surabaya. Thank you. Yeah. Any other participant that online at the moment? I think that we have to move further. Yeah, because we are short of time. I think that we have to finish this all these 7 cases, because the 7 cases will be presented on the my website. Okay, and we would like to actually we have 3 more questions that come from audience that I think that it is very important. The first one is for Professor Joseph. Professor Joseph, are you online still? Professor Joseph?
Yes, I'm here.
Yeah, the question is that they asked that what is the mechanism of anemia in COVID-19?
Well, I think, in my opinion, there is no specific etiology that is not a specific factor. It's a type of anemia which is related to cytokine storms, which is similar to anemia of chronic disorders, and due to a sort of block of iron metabolism and the suppression of red cell production, mild suppression in the majority of cases. And I think that some new information comes from the manuscript I showed before by Dr. Wang, who showed that reticulocyte can be increased in critical patients. And this is an interesting piece of information because it is something different from the hypothesis of anemia of chronic disorders related to the inflammatory condition. Sorry.
Yeah, and at least.
So I think it's interesting to have more information. I would be very interested in knowing more about reticulocyte in the different phases of the disease. That could help very much to understand better. For now, I think that the mechanism is the one of suppression of erythropoiesis and block of the iron metabolism due to cytokines.
Well, but because there's from work of Professor Wang showing that there's some increase in reticulocyte and also increase in the RD. That means that the bone marrow should be still active in producing the red cells.
This is, I agree with you. This is what I get, that it will be interesting to know more about reticulocyte in the patients. And we don't have many data concerning reticulocyte. It is possible that something different. We also heard about schistocytes. There was a question about schistocytes. There may be some microangiopathic mechanism is also active, but in severe cases with blood, with the intravascular coagulation. So that could explain.
We have other very important questions that raised by.
Can I add something? Can I add something? Yeah.
Yes, please.
Yeah, I was reviewing the role of COVID-19 and anemia, and what I found is clearly what Dr. Donofrio, Professor Donofrio said, that there is an increase of IL-6, and due to that, epsidin and anemia of chronic disease is a clear mechanism of functional iron deficiency, that the iron is going to the form of ferritin and decrease the saturation, decrease the serum iron, increase ferritin. That is clear, but also has been proposed by other authors that this COVID-19 has attacks the M on the beta chain of the hemoglobin. For this reason, also that maybe will help to understand some of the findings we can see in the red cell morphology of patients with moderate severe and severe critical, in that we see features that maybe are not so frequent in anemia of chronic disease. It's just to add something to the anemia discussion.
Some of these red cell change may find in the case of DIC. You sure that this is not because of coagulopathy and intravascular hemolysis?
Yeah.
Do you agree, Professor Donofrio? Yeah.
I have other questions that no one touched on before. I don't know who will explain. The question is that, are there any change in the ESR, erythrocyte sedimentation rate, in COVID-19 cases? Dr. Joseph Lopez, who can respond to these questions?
I don't know, Ramon, if you have an answer. I think that I've not read any paper about this, not in our journal. I think that, of course, it will. There should be some change in ESR due to the inflammation. I don't know if anybody has studied this time of honor test, but which is now more commonly substituted by PCR or.
I think the IL-6, is a clear increase of IL-6 or all the inflammation, and I am sure it is an increase of ESR because if we can see all the interleukins, the CRP, for sure, but I have not seen, maybe because it's not so fashion, the sedimentation rate. I will review it, but I have not seen any, but all the other inflammation markers are positive, has to be positive too.
Maybe it could have some prognostic value.
Yes.
So it's not
and it's cheap, and yeah.
I think that we have to come to the end of the session. Before we close on the session, we have to make announcement of the award winner, right? Yes, these are the three presentations that have been selected by the committee to be the contest winners. The first one is Dr. Aida Tabit from Kuwait. The second one, Dr. Immanuel Ratan from India. And the third one is Dr. Miftah Hasna from Indonesia. Congratulations again. Yes.
Congratulations.
And just before we finish this webinar, I also would like to thank all the participants. From what I can watch from the chat box, we have at least people from 13, 14 countries, no, 16 countries, from Africa, from Europe, from Asia, and also from India, that you can say that part of Asia as well. Participant, and I have 8 participants that don't know where, they did not identify where they come from. Okay, so at least we have about 25 or 30 people from different countries. And I would like to thank all the people who submit cases, the first 5 and the next 7 cases that we have been already shown in this free talk discussion. Everybody can go into the Mile Lab Club and look at all this presentation, and we need to get the vote from you for the next winner. Okay, thank you very much once again for your participation, and looking forward for the next webinar or HemaTalk of Myre. Thank you. Have a good night or good time, good day. Yeah, this is the QR code if you want to go to the lab club. Okay, thank you very much.
Thank you, Dr. Professor Donofrio.
Ramon, thank you very much.
Thank you. Thank you.
Bye bye, Sultan. Thank you.
Thank you.
Bye. Thank you very much. Yes.
See you soon.
Yeah. Hope that we can do better next time.
It was not bad. It was good.
Not bad. Absolutely not.
Great job.